So, very good morning to all of you. I'd like to thank AIS organizers for having me in this session. So, I am Dr. Shorya, and I'll be speaking on PCR in uveitis. Is it indispensable? So, first, this is the outline of my talk. So, first, I would like to talk a bit about how we used to approach a case of uveitis previously and how these tests have actually added value to it. And then we'll go to the test basically itself, the pros and cons, the indications that we use, the available literature that we have, few cases that we saw in our practice, and then a take-home message. So uveitis is like medicine. So it's like an art of diagnosis, just like combining your history and your symptoms and signs, and then coming up into a pattern, finding some pivot, sort of a key finding, going to a differential, narrowing down your differential, and then you make a diagnosis. That's a probable diagnosis which you can confirm with a test. Now, why I share this article is that these articles used to come much more earlier when these tests were not there, and we used to basically depend more upon our clinical findings rather than these tests. So this was somewhere published in 1982. This was some 2-3 years before the PCR test came. So putting that into practice, if you see, this was a case which was a 38-year-old male who had come with complaints of defective vision, and he was given oral steroids for some time, and the patient landed up with us who was not responding to oral steroids, and you could see that there was anti-segment inflammation, there was media haze, and there was these retinochoroidal patches, there was arterial involvement, as well as this pigmentary change that was there. So putting the pattern, pivot, and cause diagnosis, confirm sort of art of diagnosis into picture, we had two basic differentials that we had. One was toxo and ARN. All these findings were quite similar in both of them, unless until we saw the other eye, in which there was a pigmented scar and which was more towards toxo. When we went ahead with serology, it was positive, and then we treated this patient, and the patient showed a good response and improvement. So what if the serology was negative? Was it the wrong diagnosis? Well, I still would have gone with the same diagnosis, but yes, retinitis, when viruses, bacteria, fungi, all these can actually make things a little bit, unclear and sometimes confusing. So we actually presented this case in one of the conferences, and we were asked why we didn't go ahead with PCR. So should we have done a PCR? We could have identified maybe or ruled out a viral etiology. So a lot of patients in which we do not go ahead with tests and we label it as idiopathic may actually land up being some sort of a etiology if we do the PCR. So what exactly is a PCR? PCR is nothing but a molecular test in which we amplify the DNA or the RNA. What is required is a template, primers, enzymes, nucleotides, and buffers. We put it through the steps of denaturation, annealing, and extending, and then we amplify it. How it has evolved now? Well, it's the one which was always there, as ma'am also spoke during the COVID times, the RT-PCR, which we all know, we have all already gone through it. It's basically a qualitative quantitative test in which we can see the disease severity. We went on to multiplex PCR, where we could actually assess for more pathogens, and then to combine both of them, we went to comprehensive, which was first multiplex of trying to find out the pathogen, and then real time to actually amplify them and see for a disease burden. There are more modifications like broad range, strip PCR, and next generation sequencing, in which we can test for more pathogens. So what are the pros and cons? Well, it is a small quantity is required, it's rapid, safe, accurate, and also reproducible. However, the cons are also there. So the positivity is only 50%, there is chance of contamination, there are false positives because of contaminations, there can be false negatives. So if your sequence of an organism which you're trying to look is not there in the test, then it will be for false negative. Even dead organisms can actually come at false positives, and we have to be ready with a narrow differential. We just can't be like we are doing a PCR test and we don't actually have a probable diagnosis. It also requires a specimen of a good quality, so it has to be taken at the right site. It has to be taken at the right time, as ma'am was saying that it has to be taken in the right time period during the infection, right technique, and also transportation. The interpretation also requires that it has to be somewhere connected to the diagnosis, and it is more applicable in viral infections, and contamination is always there, as I said. So the indications that I would say would be that in the case of pan-uveitis, and I'm not talking about those pan-uveitis which are quite clearly, we know the diagnosis like say a Behçet's or a sarcoid or a VKH. Not those, but the ones in which you want to rule out an infectious etiology, maybe an endogenous endophthalmitis or a post-operative endophthalmitis, maybe the patient had undergone a cataract surgery somewhere. So those sort of patients, we can go ahead with a PCR. Even as I said, as I showed the case that of toxoplasma, retinitis can be confusing. In those cases, we can go ahead. In cases of anterior uveitis, where you want to confirm a viral etiology, you can go ahead with PCR. And some associations like Fuchs, Posner-Schlossman have some associations with viral etiology. In those cases, you can do a PCR. So if you search in PubMed right now, you will have some 1200 publications, and mostly PCR is utilized for infectious etiologies, and the ones in which it has been done is basically anterior uveitis, and the common organism is viral. So what do we learn? So mostly it is to rule out infectious etiologies. For an Indian scenario, most of the times it has been done for posterior uveitis like retinitis. The site is more commonly aqueous than vitreous, and etiology, as I said, is both viral toxo. The positivity here is a little different, that it is 50% in cases who are immunocompetent patients, but 85% in immunocompromised. So probably it holds a value there. The treatment change on the basis of PCR is seen anywhere in literature from say 13% to somewhere around about 38% has been said. So it's a little variable. And when you don't have any clinical clues and no suspicion, then the predictive value of this test is not actually good. And sometimes when you just want to confirm it, then in those cases, it is actually beneficial. So now I'll just move on to a few cases. So this was a patient who came up with defective vision and was having a necrotic retinitis in the periphery, focal retinitis in the center, and some hemorrhages over here. So it was an immunocompetent patient, and we were confused how it was. The patient had already received a PST injection elsewhere, and so again, according to the findings, what we thought is probably it's viral because of the fact that there was the peripheral involvement, the hemorrhages, and we started on antivirals, but the response was not there. So then we move ahead with serology, and that was also negative. So then we did a PCR where it came out to be a toxo. When we treated, you could see that there were healing edges and pigmentary changes. Again, another patient. This patient was a patient of ALL, a young patient who had these hemorrhages and focal retinitis over here. We thought it to be CMV. We sent for a PCR. It was negative. We went ahead with the treatment, and it resolved. Another case, in this patient, we can see that there are hemorrhages, there is a prostate branchitis. It's more of that we know that it is a case of CMV. It's an immunocompromised patient, and when we confirm it, it's positive. And you can see it also responds to your treatment. So to summarize, in a setting like ours, in a developing countries where infections are there, it can be done in certain cases. We are not coming to a diagnosis or whether it's not responding to our treatment. We should not put it for routine testing. It should only be when we have a clinical suspicion. Interpretations should also be interpreted according to the case. It should not be that just because it came positive, now we are labeling it to a specific etiology. Undifferentiated diagnosis, it's not as if we'll just put in some sort of a test and it will come up with a diagnosis. It's not like that. It's more or less the differential that we have, and it might hold some importance in an immunocompromised patient. So atypical presentations are there because of their altered immunity. So there, in those cases, it might still hold importance. So I took this from an article. I don't know the reference. I'm sorry. So idea of performing a diagnosis test is to increase or decrease our suspicion that the patient has a particular disease to the extent that we can make a management decision. So thank you.